My job during this talk is to build the bridge from understanding obesity from the previous two presentations to treating obesity, which is going to be subsequent presentations. And again, we'll only discuss adults, not the pediatric population. And we have to start by first thanking each other, right? You're all on the front lines. We're all there. And so just showing up is really important. And when you are in the room with patients, we know that they're showing up with hope and fear, frustration and courage. And obesity care is complex and it requires a partnership. So Dr. Oshman's presentation just previously really helped us sort of think about that. And today is about making what we've learned so far practical and doable. Again, disclosure, I do work at Zero Longevity Science. I'm not going to be talking about fasting today. So feel free to drop a word or phrase in the chat. What makes conversations about weight challenging in the clinic? And just think about why this is even something that we have to talk about, right? How do we go there? How do we have that conversation? And I see this question come up frequently when I have learners in my office shadowing or working in our clinics. I won't be able to see the chat right now, so all right. So here are the objectives for today. I want to make sure we all learn to apply a simple, time-efficient framework for obesity assessment. Then integrate weight-relevant assessments into your busy clinic for better outcomes. And develop confidence in meeting patients where they are and guiding progress over time. I'm going to use the term overweight and obesity throughout this presentation for the medical purpose, but we talked about weight-inclusive language and all of the weight bias and stigma. So please understand, I'm just going to use the term overweight and obesity for the purposes of this conversation together right now. Oops. Let's see. So why do assessments matter? Guidelines agree that obesity is a progressive chronic disease and that delaying treatment delays recovery. Why? Well, we know that you have better outcomes if you treat earlier in almost any disease process. It preserves metabolic function and quality of life. It improves long-term weight trajectory so that you might not need more intensive treatments later. And it reduces stigma by treating overweight and obesity as the same way we would other health conditions that may lead to poor outcomes. Guidelines differ. There are screenings, the role of meds and surgery, and that can also be complicating our entire treatment of patients. So what does that look like? Oops. When to start screening? We have the American Academy of Pediatrics says start at age 2, but the U.S. Preventative Services Task Force and the AFP say 6 and above. What to screen? We've got BMI only, or do you also integrate other factors such as waist and comorbidities? There's ethnic-specific BMI cutoffs, which we saw in the chat. There were a lot of questions about that. The ADA recommends BMI of 23 and above is a cutoff and a positive screen, while others recommend BMI of 25 or 30 and above. What about screening frequency? The American College of Cardiology and the American Heart Association says screen at every visit, and then other guidelines vary across different organizations. And then what about the role of meds in surgery? There's a lot of different thoughts in this space, and the AAFP is together with the USPSTF in saying not much about specifically making recommendations there. But then there's other organizations that have recommendations for select populations or in certain case scenarios. It's no wonder this is confusing. So what I want to do is make this easier, help build confidence, and improve outcomes. And so I'm going to share with you some of what I've learned from doing this. I was board certified in 2013 for obesity medicine. And so I've sort of seen this develop and I've made all the mistakes. I've done all the wrong things. And so I want to make sure any pearls that I can share with you, I want to make sure we do that. I always start out by thinking about the clinician mindset. Then I'm going to share with you the ABCDE framework. We'll apply that framework to clinical case vignettes. And then I want to share with you a few tips from the front lines and some resources in addition to the ones that you've heard about already. These are different, and I just want to share some additional resources. So mindset matters. Even before you see a patient, that mindset matters. And that's because it's going to save you time, and it's also going to help protect you against burnout. What's the problem? Whether you're the patient or the provider, sometimes it feels like there's a really long road ahead, right? A lot of steps to climb. And we've seen lots of different ways obesity is complicated. This is one that I used early on when I first was, practicing. I like this picture, not to go into it, but because again, like Dr. Oshman showed, there's so many contributors to obesity that it's really important to recognize there's no way you are going to cover all these topics in one visit. So you need a way to do this where it fits into the clinical flow. And again, giving a patient a handout that says eat less, exercise more is insufficient if you really want to treat obesity because it's complicated. Then we've got the challenges for clinicians in obesity care. These competing priorities like multiple diagnoses, new meds, mental health needs, paperwork. The system barriers, insurance coverage, prior auths, limited reimbursements. We've got patient factors. Sometimes they're not ready, or they don't follow up, or there's unclear benefit. And then provider concerns. We don't want to create harm. And there's uncertainty about where to start, the time pressures, and then some people are just feeling burnt out in the whole space. So many providers will say to me, I would love to help, but where do I even begin? There's so many things I need to address in a visit. Or they might even say, I just don't know how to get started. We've already kind of got some really great tools from our earlier presenters. Now, imagine what it takes for a patient to walk in. Many of our patients have carried the wounds from that disappointment, the judgment, the negative responses, the weight bias and stigma that we just heard about in their healthcare experiences. And so we can recognize this and understand it takes a huge amount of courage to schedule. And I always remember that when I'm going in to see somebody. It's also human to want partnership. We know that from clinical experiences, from the Obesity Action Coalition, for a bunch of patient voices in various areas, they want to be heard, understood, and respected. We all do. We want safety and unconditional support, personally relevant options, and adaptability. So many times when patients come to see me in our weight loss clinics, they will say something like, I want something that is really specific to me and where I am, not just standard one-size-fits-all approach. And I might need to change it because my life circumstances change. And then again, clear, actionable next steps so that they know what to do instead of just a general guideline. I always find the beautiful part is we all have shared goals. Everybody wants to be healthy. It doesn't matter how old you are. You want to feel good, have independence, no limits, freedom to live the life that you've desired, that optimizing quality of life, disability-free years, and life after retirement. And that's pretty standard, right? So we can know we're all on the same page. So before we walk in the room, I like to orient my mindset when I go in. Obesity is complicated. I'm appreciating their courage in showing up. And then this commitment, I'm thinking about this as a long-term partnership, and we're committing to each other. Obesity and obesity care are a lifelong experience and journey that we get to walk together with. So now we want to talk about obesity care and this way of simplifying obesity care, understanding one of the benefits of primary care and family medicine is we get to see people over time. So you don't have to hit everything all at one time, but if you have some kind of systematized way of taking care of obesity, it becomes easier because each visit you can plug away a little bit more and help an individual achieve better health for themselves. So the ABCDE roadmap for obesity care. It's very common that I'll have learners come into my office and start taking a history and get lost. They might veer off in one direction or fixate on one area, or a patient is sharing a story that's very complex. And so it helps to have a framework that allows you to zero in and make sure you're getting the information you need to provide the best care for your patient. A is for acknowledge and open the door. B is for BMI, body composition, and waist circumference. C is for comorbidities and complications. D is about determining the root cause and the drivers for excess weight. And E is about evaluating data, the vitals, exam, and labs. So acknowledge and open the door. And you've heard this already earlier. We have to respect the patient's experience and create a safe space to begin the conversation. I'm always thinking, how can I create a future opportunity for a patient to return to my clinic and be effective in my help, right, with the chronic medical issues and or weight? So it's really about providing a warm invitation that I'm a safe space to talk about this, and I'm here for you, right? We look at BMI, body composition, and waist circumference. And I love that we've really hit on, you use BMI for screening, sort of, but it's best to add body composition or waist circumference to assess metabolic risk and stratify health impact. This is very, very important, as we've already heard, so I won't dwell on that too much. And again, providing the warm invitation. I actually usually don't ask if I can talk about it. I'll say something like, let me know if you'd like to work on that together in the future. And that just opens a door, and people will either lean forward and say yes, or they sit back and they cross their arms, which gives me some very clear signals as well, right? So, but I just want to open the door that I'm here for conversation about this. So again, BMI is what guides treatments, right? And so we do have to actually document that so that we can appropriately categorize individuals, even though it's not a perfect measure. So again, underweight based on WHO guidelines is less than 18.5. Overweight begins at 25 based on the WHO for the general population. However, as we talked about just previous to this presentation, in Asian populations, the numbers might start a little bit lower, where overweight begins at 23. Obesity, which is a BMI of 30 and above, or in Asian populations, 25 and above, that can be broken up into 3 different classes. So again, I also will never use the term morbid obesity. Yes, I have the same experience, Dr. Oshman. So I use class 1, class 2, and class 3 obesity so that it's very clear. And I also want patients to understand these are diagnostic terms. So it goes in the chart, but it does not tell us risk factors. I do look at waist circumference, and that I find is much more indicative of risks to an individual. So females greater than 35 inches and males a waist circumference greater than 40 inches. Just good to have those numbers. BMI is not perfect in athletes, individuals postmenopause, various ethnicities, and age can affect how relevant BMI is, right? MHO, metabolically healthy obese, individuals with a BMI that puts them in the obese category. However, they are metabolically otherwise healthy. That might be like a bodybuilder or an athlete. TOFI is thin on the outside, fat on the inside, meaning visceral fat, right? So somebody who looks slender on the outside, but they actually have higher visceral fat and maybe having metabolic dysfunction. Also, interestingly, in individuals 65 years old and above, there's increased mortality with a BMI less than 23 and above 33, which if you think about it, that means a normal weight, overweight BMI, and class 1 obesity BMI levels are all considered good for individuals over 65. So again, BMI is not perfect. But BMI guides treatment options. So again, here's how I think about this. Across all BMIs, lifestyle matters. It's about nutrition, physical activity, and behavioral strategies. We're going to hear about that next. So that will be helpful in our future presentations. Medications start at FDA indicated from a BMI of 27 with comorbidities or 30 and above, and metabolic bariatric surgery from 35 and above with comorbidities or 40 and above with or without comorbidities. Now, in 2022, the ASMBS did come up with some new guidelines that suggested that for certain populations, metabolic bariatric surgery would be indicated from a BMI of 30 and above. And so I'll leave that for the discussion later today about bariatric surgery. Now we've done A and B, right? We've acknowledged, opened the door. We've assessed the BMI and body composition and waist circumference so we can understand some of the risks for individuals based on their weight. Now, comorbidities and complications. We've talked about this a little bit earlier. I'd like to clarify with some of my learners, comorbidities are processes, disease processes that go alongside and are often associated with excess weight that's metabolically unhealthy. And then complications can be things that get worse or are aggravated based on overweight and obesity that's metabolically unhealthy. Talking about heart disease, high blood pressure and cancers, liver disease, GERD, PCOS, infertility, mood, mental health, disorders, osteoarthritis, dementia, sleep apnea, metabolic syndrome, prediabetes, diabetes, lots of inflammation, immune system dysfunction, which lead to worse pain, surgical, and COVID outcomes. These are all associated and or aggravated by excess metabolically unhealthy fat tissue. And so when I see this, I might be more inclined to treat a little bit more aggressively for individuals who are having multiple comorbidities or complications. D, this is determining the root cause and drivers. And we've heard about this earlier, so I won't go too far into this, but we're really talking about psychosocial, biological, and environmental factors that can really drive the outcomes. Social connections and support, cultural beliefs and identity, shift work, caregiving responsibilities, stress, biological components, hormones, genetics, substance use, medical history, medications, and then environmental, food access, the neighborhood, right? Are there a lot of obesogens there? Built environments, again, how is that environment built to help support health? We want to keep in mind social determinants of health and health equity. And all of these factors are really important. So learners will ask me, how do you ask these questions? How do you get to this? How do you do this in a time efficient way? So I'm going to give you my questions. All right, here we go. Weight history. When did you first notice weight gain? What was your highest and lowest weight? And when did you feel your best? Right? Very helpful to kind of orient you. Dietary patterns. Walk me through a typical day of eating and drinking. Are there times when eating feels hard to control? Now, this typical day of eating and drinking, I'm listening for if somebody is hesitant to share with me food insecurity as well. So this is really important just to kind of understand where we are with this patient. Physical activity. What's your current movement or physical activity? Any limitations? And I'm wondering if there's fatigue or pain or mobility that's interfering. Sleep and stress. How are you sleeping? And what are your biggest stressors? This really helps me prioritize together with the patient. If they say, something very serious is going on and they're extremely stressed about it, I might say, okay, maybe let's focus on that first with whoever you're focusing on those concerns with. Maybe it's mental health, whatever it is, so that I give them permission to postpone or to redirect their energies as needed to address anything that might be a more pertinent stressor right now in their life. Medication and medical history. Are there any medications affecting your weight that you've noticed? Is there a history of diabetes, PCOS, fatty liver, thyroid disease, depression, substance abuse, eating disorders, sleep apnea, trauma? Lots of things can interfere with weight for many individuals. And then the social factors and support. What supports do you have? Are there any barriers to making changes? And I'm listening for things related to maybe cost, food access, work schedule, caregiver responsibilities, so that I'm not going to give them some ridiculous recommendation if I know they're not going to be able to fit that into their life, or that I might ask them, is this something that could be helpful for you? And E, that's about evaluating the data. That's bringing it all together. This is with the exam, the labs, looking for insulin resistance, looking at a med review for weight positive medications on their list, and understanding if they've tried or are currently on medications to treat obesity, or have they had bariatric metabolic surgery before. So the targeted exam for obesity, find this to be pretty straightforward. It's not anything unusual, and so you'll already be doing this part of your regular visit. So vitals, blood pressure with the proper cuff size, heart rate. This is important so I know what the baseline is, because if we are thinking about medications, those medications can often affect heart rate dramatically. And then other measurements, the weight and the height, the body composition and waist circumference. Now with the weight, the hardest part is if you work in a larger organization, they may decide to put the scale in the hallway or in the waiting room. And I think it's really important that it's in a private space. So you might have to advocate for that. I've had to do that in almost every clinic I've opened. Capacity. The weight also has to be able to weigh the people you are putting on the scale. Waist circumference. That tape measure is not the one that you measure somebody's, a baby's head circumference with. It has to be long enough. The appropriate way to measure waist circumference is at end exhalation at the iliac crest, at the top of the iliac crest. Now, in my practice, that just doesn't go over very well with our patients. They find different users, different medical assistants, whatever, are not measuring exactly the same, or they didn't get enough of an exhalation or whatever it is. So we do it sort of not the appropriate way possibly, but I ask individuals to get their waist as small as they can. So suck it in, and then we put the tape measure around their belly button and just go right around. And that way they can also do that at home. And people feel satisfied with that measurement when they are working on their weight. And so that seems to work better for us, but not the appropriate way based on what the literature shows. All right, what about key physical exam findings? Acanthosis nigricans, that discoloration on the back of the neck, in the skin folds, skin tags, clues you into insulin resistance. Central adiposity also clues you into insulin resistance and increased metabolic risk. If you're noticing on a joint exam or their range of motion or their gait is somehow abnormal or difficult, you might be looking at osteoarthritis, mobility limitations. That's going to affect recommendations and how to take care of your patient. Signs of obstructive sleep apnea. So we might look at neck circumference, look for crowded airway or reported daytime fatigue. And then edema or venous stasis, in addition to the earlier vitals, might give you some indication that there's cardiovascular risk involved. When we start finding more and more pieces of the puzzle that show that an individual really could feel so much better addressing their weight, this is helpful. So I use this to kind of nudge me in, what I'm recommending. Now, we also want to look at the labs because that tells us a lot. So an A1C, lipids, or an ApoB, fasting insulin. I ask for 12 to 14 hours fasting for insulin levels. Renal function and electrolytes, LFTs, thyroid panel, vitamin B12, vitamin D. These labs are often routinely captured. Sometimes I have to add on the insulin. If somebody's had abnormal lipids in the past and they're not sure and their triglyceride to HDL ratio looks pretty good, I might order an ApoB just to get clarification on atherogenic particles. Then once we have all this information, one of the things I'm looking for are the clinical clues of insulin resistance. So from the physical exam, we talked about central obesity, acanthosis nigricans, acne, acrocordons, males with hypogonadism, females with frontal balding, hirsutism, PCOS. I might be looking at lab or biomarkers. Somebody earlier had asked about insulin levels. I look for fasting insulin of 8 or greater, triglyceride to HDL ratio greater than 2, or an A1C of 5.7 or higher. And then I'm like, okay, this is definitely, we're in the insulin resistance stage. Metabolic syndrome, the NIH has 3 out of 5 is their criteria. Blood pressure of 135/85 or higher, waist circumference of 35 inches for female, 40 inches or higher for males, fasting blood sugar of greater than 100 milligrams per deciliter, triglycerides greater than 150, and then HDL less than 50 for female and less than 40 for males. Again, when you see these numbers and 3 out of 5 of them are positive, this individual has metabolic syndrome. And then if you do not want to use the term class 3 obesity or class 2 obesity in your medical record, you could indicate metabolic syndrome, which captures this risk. Now, I'm not going to go through these charts, but I wanted to share because I've been collecting this for years. And so I just put this together over many years, and I wanted to make sure you all have this. So on the far left side, you'll see these are the medications that cause weight gain. In the middle column are alternatives to those medicines that are a little bit friendlier for weight. And then if you're not used to prescribing those alternatives, I put in the far right column the things you need to know about the potential risks and contraindications to those alternative medications so that you can easily choose and identify who's appropriate for those meds. And this is page 2 of that. And I highlighted 3 medications here because these specific medications, individuals will come to my office, and it turns out many of the patients don't know these medications can cause weight gain, and they feel a little bit upset that their primary or their specialist or any provider has not told them about it before. So tricyclic antidepressants, specifically amitriptyline and nortriptyline, we'll see individuals be put on those for multiple different reasons, and they can cause between 33 to 44 pounds of weight gain in 2 to 6 months. So if somebody thinks they're working on their weight and they're like, I don't know why, I'm doing all the right things and my weight's not budging, and I was started on this medication, that could be why. Valproate also can be like 44 pounds. And then we've got gabapentin. Now that we're being very careful with opioids, I see a lot of specialists who are treating pain, providing gabapentin for neuropathy or pain. And that leads to, a lot of weight gain within 3 months. You could see over 30 pounds. So again, be aware and understand these can be aggravating the weight efforts. Also, I'm thinking about what are all the treatment options for the patients. I like my patients to have freedom of choice and to understand what their options are. So in order to do that, I'm also in my brain, as I'm evaluating, I'm thinking through and asking the questions to understand what's appropriate and what might not be okay. So is somebody planning a pregnancy soon? Are they pregnant? Are they breastfeeding? Then definitely we're not going here, right? Indications for medications or surgery. Is it even indicated? I will have individuals come to me with a BMI of 22 who are like, I'm ready for my GLP-1. Yeah, that's not happening in my office, right? So recognize what the indications are. History of cardiovascular disease, tachycardia, arrhythmias, uncontrolled hypertension, mental health concerns, depression, mood and food coping. If somebody is using food as a coping mechanism, and I'm going to start addressing weight with them, and we might be talking about food, that will be very challenging if the person doesn't have other coping mechanisms, and it can actually spiral. And so I like to make sure in those individuals that we are taking care of the mental health components first, and there's a plan of action in case there's some de-escalation of some of their coping skills, and it becomes a problem for them. Substance abuse. Oftentimes, if you reduce somebody's, for example, sugar intake, they may go to a different substance. And if they have a history of a substance abuse history in the past, that could be very risky. So I really take mental health very seriously. History of seizures or opioids, right? We know what medications we may or may not use in those scenarios. Chronic kidney disease, kidney stones, past medical history or family history of medullary thyroid cancer, MEN2. We know what we're talking about. And then past medical history of pancreatitis. What about glaucoma or diabetic retinopathy? I need to know that as well. History of or a high risk of intestinal obstruction. This is important for medications that delay gastric emptying. And then inadequate protein intake. This is super, super important to me to make sure I do not, aggravate or have some way of causing sarcopenia. This is very, very important. So a lot of times we forget to make sure people are getting adequate protein intake, especially as they get older. Good news, we can help, and you can use the ABCDE framework to help guide your patients. And over time, you're collecting those pieces of data so that you can choose what are the ways you're going to take care of individuals. As family physicians, any of the lifestyle methods, nutrition, physical activity, behavioral strategies are all fair game and very useful. We're not talking about the device, the super absorbent hydrogel today. And then prescription medications, BMI 27 and above with comorbidities or 30 and above. Those are really the options that we have in the clinic if we want to treat overweight and obesity. In addition, you can refer. So metabolic bariatric surgery, again, BMI of 30 with comorbidities or 40 and above. 35, did I say BMI of 35 plus with comorbidities or 40 and above. Then you could send for bariatric consultation and understand what the options are for that patient. So again, use the ABCDE framework. If that helps, make sure you're collecting the data in some systematized way so that at each visit, you can kind of plug some more information in and it doesn't have to be, taking up the entire clinic time. All right, so I want to apply the ABCDE framework to 3 clinical case vignettes. Again, in this presentation, I'm trying to bring together the earlier 2 conversations, the presentations that we had, and what I just shared with you right now. So let's get going with this. So clinical case vignette number 1. This is Mary. She's here for a yearly physical. She's a 47-year-old female who's 5'4", 190 pounds with a BMI of 29 and a waist circumference of 36.5 inches. She's had gradual 15-pound weight gain over the past 5 years. And so again, if we look at the ABCDE framework, we can acknowledge and open the door. If this patient is telling me she's gained weight or she's indicating that there's some concerns with menopause around the corner, I might offer, let me know if you want to talk about your weight. I'd be happy to do that at a future visit. I might also be in my mind recognizing this BMI, may or may not be helpful, but the waist circumference is 36.5 inches and her weight is trending up. So I might just flag a little note in my brain. To determine whether I want to further assess this patient or work with this patient a little bit more, I'm going to look for complications and comorbidities. She has none. We had the exam, everything goes well. I want to look for root cause and drivers of why she might be gaining the 15 pounds, because if it's something like medication effects or whatever, I want to recognize that and help nudge that. She reports a sedentary and stressful job. She's sleeping 5 to 6 hours per night. Okay, that gives me some information. And so I'm going to evaluate the available data. Blood pressure of 130/78, heart rate of 76. The exam is otherwise unremarkable. So she's actually doing fairly well, and she may or may not be interested in working on weight. Her labs show an A1C of 5.4%, triglyceride 120, HDL 56. The rest of her labs are fine, along with her renal function and LFTs. So she's actually okay. So my assessment in this case would be a 47-year-old female with gradual 15-pound weight gain over the past 5 years. She's overweight with a BMI of 29 and a waist circumference of 36.5. She has high stress level, sedentary desk job, and disordered sleep. What are the indications? Well, lifestyle, right? So she does not fit the criteria for medications, and lifestyle is actually appropriate. So what else would I think about for maybe a future visit or to start planting the seeds? I might think about addressing sedentary lifestyle. We might talk about stress or sleep. And those are things that I can have the conversation with her. And she says, you know what? I totally want to work on my weight. So she's going to follow up for weight management. I'm not going to try to squeeze that complex visit into this plan and this visit right now, right? Hopefully that makes sense. And we will go on to clinical case vignette number 2. All right, so Joe, he's actually coming in because of weight gain. 52-year-old male, 5'9", 230 pounds, BMI of 34, with a waist circumference of 42 inches. He's gained 20 pounds in the last year. Again, we can acknowledge and open the door. He's already opened the door for us. And we reflect on the BMI and the waist circumference, and we recognize he appears to be at higher risk, right, based on that information. Now I want to understand, are there complications, comorbidities associated here? He has a past medical history of hypertension and bipolar 1 disorder. He has a family history that's negative for medullary thyroid cancer or MEN2. I look at the root cause and drivers. He's got medications. One is lisinopril for his blood pressure, and then olanzapine. And when I look at the olanzapine, my red flag goes up, right? Because that's a weight positive medication. Now I'm going to look at the labs. Blood pressure and the exam, I kept the same as the previous individual so that we will focus on labs, which are new here. An A1C of 6.1%, triglyceride of 220, HDL of 38, an ALT of 46, AST of 38, and BUN and creatinine are normal, as are the other labs. He did not have a fasting insulin level. He was sent without. So here's my assessment here. 52-year-old male with well-controlled hypertension and bipolar disorder and class 1 obesity with a BMI of 34 and a waist circumference of 42 inches. He's gained 20 pounds in 1 year on weight-positive medication olanzapine. He has metabolic syndrome based on the criteria and insulin resistance with an elevated waist circumference, hypertension, prediabetes, elevated triglycerides, low HDL, and his LFTs are slightly elevated, consistent with fatty liver. So what's indicated in this individual? Again, lifestyle and medications are definitely indicated in this individual. In our clinics, we would not do both at the same time on the same visit, but those are both appropriate. What else? There's these weight positive medications, right? Or at least one, the olanzapine. So we would want to kind of learn about that and also consider follow up these labs to make sure we're trending in the right direction and not going in the wrong direction, in which case we might amplify and accelerate our treatment plan. We talked to him and he does not want to change his olanzapine prescription. And the reason being, he was really scared when he was hospitalized previously with a manic episode, and his olanzapine has kept him in check. Totally cool. He'll begin walking 10 minutes after meals, and he's going to avoid alcohol. He is open to starting metformin, which can help mitigate the effect of olanzapine and also be useful for the prediabetes. And then we may refer or follow up for weight management. He will confirm additional medication coverage with his insurance in case he's interested in one of these incretin medications, which increasingly are having evidence that shows it's helpful for fatty liver and would be helpful for a lot of his other comorbidities. All right, clinical case number 3. Knee pain, she desires knee surgery. This is a 60-year-old postmenopausal female who is 5'3", 242 pounds with a BMI of 43 and a waist circumference that puts her at risk. Her knee pain is limiting mobility and she desires knee surgery. So she's been sent to our office from the orthopedic surgeon. Now, we're acknowledging and opening the door. I'm happy to talk with you about this. Let's go there, right? BMI, waist circumference are elevated. We've already checked that. Now we want to understand the complications and comorbidities. She has type 2 diabetes, hypertension, fatty liver, osteoarthritis. Her family history, she has no history of medullary thyroid cancer or MEN2 in her or her family history. And her prescription medications include gap in care, but she is taking her metformin. She also has a prescription for lisinopril, and previously she was on phentermine. Now we're going to determine the root cause and drivers. She has acanthosis nigricans, skin tags, consistent with insulin resistance. She's got limited mobility with her osteoarthritis of bilateral knees and possible sleep apnea. Now we look at all the available data that we have in addition to the above. And I've changed out the vitals so that the blood pressure is 148/88 and heart rate of 86. The labs below are the same as the gentleman before us. A1C of 6.1, triglycerides of 220, HDL of 38, an ALT of 46, an AST of 38, and a BUN creatinine within normal limits. Also, no insulin available on the visit. So here's our assessment. 60-year-old postmenopausal sedentary female with class 3 obesity with her BMI and waist circumference, with bilateral osteoarthritis of her knees, limiting mobility, and she desires weight loss for knee surgery. Her additional comorbidities include metabolic syndrome with type 2 diabetes that's well controlled on metformin based on that A1C of 6.1%. Hypertension was not well controlled, but she reports she was not taking her lisinopril. Her triglycerides are elevated and she has fatty liver. So the indications, she qualifies for lifestyle, medications, and metabolic bariatric surgery. What else is going on? We've got to treat the blood pressure. We want to evaluate that fatigue, maybe do a sleep study, have a behavioral health assessment, maybe physical therapy to do a little prehab before she's going to go for a knee surgery so that she can optimize her outcomes in post-surgical recovery. Easy to get stuck here, right? Wow, where to begin? So the plan, resume lisinopril to manage the blood pressure. We got to get that going. Send for a sleep study. See if that's also going to potentially help with her fatigue and her blood pressure. We discussed medication options, but she was very hesitant. She was totally overwhelmed. She doesn't come into the office very much, so she's going to think about it. And we can refer or follow up for weight management or metabolic bariatric surgery consultation, depending on what she's seeking and what she's open to. So totally depends on the person. All right, so those are the clinical cases that I wanted to share. And now I want to just share with you some tips from the front lines and resources. All right, so if somebody has not already done this, we have to really have an office environment safety audit and training. And this is important. I'm not talking about just physical safety. I mean, emotional safety, psychological safety for the patients coming into the office. Again, leading in with people first language training or other kind of weight inclusive training. Scale placement and capacity. I say this all the time because this has been something I've had to fight for every single clinic. It does not go in the hallway. It does not stay out where other people can walk by and see an individual get up on a scale. Some people start shaking when they're going to get on a scale because they are so harmed by previous experiences of measuring their weight. We have to make sure it also has a high enough capacity. We don't want to shame anybody because a scale does not go high enough for their weight. And again, use a tape measure. I literally saw somebody using a tape measure where they ran out of the tape measure as the person was turning around. And that was a really uncomfortable experience for so many. I just can't imagine what that felt like for the patient and the provider. So, key steps for primary care. Now, this is my favorite topic, of course, and I love that primary care has long-term relationships with their patients. And this is why I became a family doc, because I actually wanted to be long-term from when you are born all the way to the grave. And so it's really wonderful because we have this opportunity to have tremendous impact. And so here's some things to just remember. Orient your mindset. Remember, obesity is complex. You're not going to cover everything in one visit. So that takes the pressure off, right? You're in this for the long haul with them. Remember, it takes patients a lot of courage to come in and schedule and even talk about weight. And we heard about, it helps to kind of even ask, what kind of language do you want to use in this space? Commitment. This is a lifelong commitment, which we make as family docs. We are committed to people for their lifetime. You can simplify this whole process and across multiple visits if you have a framework. So that ABCDE framework can help. Just remember, for the BMI, include that waist circumference or body comp measurement. And earlier we also heard Dr. Wells talking about other ways like skin calipers and bioimpedance scales, so on, to get that information. Flag behavioral health early. Whenever you see a scenario where somebody could be helped by having additional support. So if they don't have a lot of support at home, or they talk about stress eating or a history of very significant mental health history, you may want to make sure they are connected with somebody from behavioral health in case their journey along the weight trajectory and the weight care can trigger some kind of emotional experience from the past. Create a plan over time. So sometimes I'll have other providers say, there's so many things I need to cover. I don't even know where to begin. There's so many things. You just need to create the plan over time. And the next thing is the only thing you need to know, right? What is the one next thing that that patient and you can partner together on and move that forward? So that's really helpful. And then they come back. We're family docs. Use your team and the EHR tools. Obviously, family medicine is the best in this space, right? Because we know that we need a team to take care of individuals. So this is not uncommon for us. Dietitians, use your medical weight management teams. Use whatever tools are available to you. Also behavioral health. EHR, in some scenarios, makes things easier with regards to tracking or keeping all those ABCDE elements easy to review so that you can add or adapt any of the information at future visits. And use language that builds agency. We talked a lot about agency and language in the previous presentation, so I won't dive deep into there. And then consider or refer for medications or surgery when indicated. Just like we treat blood pressure and we treat other health conditions with different layers and levels of treatment, consider that for weight as well and give those options and open that door so people can talk about it. Monday morning action plan. Here's what you can do on Monday. Educate the office about weight bias and stigma, people first language, or weight inclusive language. Ease. This is going to be the mnemonic is ease. A is assess your office setup scale, location and capacity. How many times do I have to say that? Measuring tape. And those candy bowls that are sitting all over the place, probably best to remove those. I do actually have patients talk to me about the stress of being around candy bowls, and sometimes they will avoid places just because of the candy bowls. Have a standardized process and keep fine tuning. Like I said, I've been board certified in obesity medicine since 2013, practicing it since before then. And my fine tuning of this process continues to this day. It's still not perfected. I keep learning more. There's more data out there. So just remember to continue to fine tune, but create a standardized process so that it becomes easy to do and it doesn't have to sync your clinic schedule by diving into this space. And then E, engage with then acknowledge and open the door with one patient. Just practice with one patient if you're uncomfortable in this space, and it will get easier. And you'll see just that openness of patients finding this is a safe space that I can talk about this and get some information instead of trying to find some influencer online or, TikTok and make decisions from there. All right, resources. You want to stay supported and stay current. There are some additional resources. When I'm looking for obesity tools for the clinic, like toolkits, handouts, practice management tools, you can go to the AAFP website. The Obesity Medicine Association has some great resources there. And Obesity Canada, interestingly, has really great resources also. For patient-friendly education regarding treatment options and also for advocacy, I really like the Obesity Action Coalition, and the AFP, Obesity Canada, and OMA also have a lot of really great stuff in this space, in addition to the materials from the previous presenters. And then for science, guidelines, CME, practice recommendations, the Obesity Society, and again, the AFP and OMA have some really nice treatment protocols and algorithms that help guide your use of these treatment options. And then Obesity Canada also has outstanding resources. And then again, developing community programs, health initiatives, and campaigns. The Illinois Department of Public Health is actually quite fabulous in this space as well. So highly recommend all these resources. We get to inspire our patients. Brief conversations can spark long-term change. So again, you don't have to go into the whole deep dive every visit or for any of the visits, just the brief conversations, again, motivational interview, just spark that interest. What you say determines trust, motivation, and action. People can really want to lose weight, but they might not take action. But the things that you say do make a difference. And you don't have to do it all today. You're just opening the door. You get to have this long-term relationship, and that's what's really valuable. Thank you so much.
Thank you, Dr. Parrella, for that very comprehensive presentation. We really appreciate your involvement in this Redefining Obesity conference. And so we have a few questions in the chat that I'm going to present to you now. One, I just wanted to thank Deborah, for your comment and reflection. We all need to approach our interactions with patients with a sense of humility, and that's really important. So the first question I see here is, how do you determine if a patient is thin outside, fat inside?
Oh my gosh, $1 million question. Let me just stop sharing here. Okay. Yeah, so that's very, very challenging, right? So again, you might look at the waist circumference and see if that is indicative of some metabolic potential unhealth. And then the other things are looking at labs. So sometimes you'll see somebody who has a normal BMI, and it turns out that they have fatty liver. It turns out that they have prediabetes or diabetes. And that, again, right there would let you know there's something going on beyond just, it's not manifesting on the outside. Great question.
Wonderful, wonderful. I know people are commenting about the EHR, and we know that it's not a perfect thing. What about Lyrica? Does it promote as much weight gain as gabapentin?
Not as much, but it does cause weight gain. Yes, absolutely. Mm-hmm.
Okay. And what about, oh, go ahead.
No, and I was going to say, part of it is you're always weighing the pros and cons, right? If somebody really needs this medication, I'm not going to say don't take it. I'm also not going to frighten somebody that this is, weight gain that you just are going to have to suck it up and deal with. But I also want to validate it may be more difficult. So if somebody complains that their weight is not decreasing, even though they're making an effort, I want to validate that for them. And then maybe offer some alternatives with discussion with their, provider who's providing that medication.
Right. Is gabapentin dose dependent in terms of the weight gain?
You know what? I haven't seen the evidence with regards to that, so I can't say specifically. I will tell you, it seems to be dose dependent, but it's almost like it's a threshold. So it just, whatever that is for that person, if they already have prediabetes ahead of time, for example, any dosing is going to be tipping the scale. If somebody is otherwise very active and doing all the other things, then oftentimes, they can get to a much higher dose before we start seeing an effect. It might be more individual dependent, maybe.
Okay. What about low dose TCAs, like amitriptyline? Do those cause weight gain?
So most people are on relatively low dose and seeing some weight gain. It again depends. So I have found that it actually depends more on the lifestyle factors, like what that medication might be leading to with regards to cravings, or right there's other factors. Again, it's so many factors, and we have to respect the fact that we have to prioritize for the patient sometimes where the most bang for their buck is going to be. And it might be, you know what, if you cut out the soda, you may sleep a little bit better. And oh, by the way, this weight will start decreasing, right? So there's other ways that we might address that first.
Wonderful. And what about HRT? Does hormone replacement therapy increase weight gain?
That's a wonderful question. And it's actually heterogeneous responses. So some people gain weight, some people lose weight, some people feel more energetic. So then they are exercising and they're doing all the other things. So it actually depends on what their experience was prior to the HRT initiation. Great question. Comes up all the time.
Okay. And what about duloxetine?
Yeah, that also causes weight gain, unfortunately. Not as much, but yes. And actually the SSRIs and SNRIs are interesting because, we know that bupropion is actually one component of one of the medications we'll hear about later this afternoon, Contrave. So again, there's alternatives also.
Wonderful, wonderful. Yeah, Sandra, thank you. We want to thank Dr. Parrella for this fantastic presentation. I don't see any more questions popping up in the chat, but we thank you for this wonderful presentation this morning and helping us to form a practical approach to seeing patients who may be presenting with obesity in the clinic. So thank you so much for your presentation.
Thanks for having me. All right. Take care, everyone.
Take care.